Good evening, listeners. A warm welcome to Views on Health. Back with us on the program is Dr. Duleepa Baranage, Consultant Eye Surgeon, National Hospital, Kandy. Welcome to SLBC, Doctor.
Thank you,
Pleasure to have
Fatima.
you with us.
Thank you, thank you.
And Dr. Duleepa Baranage is going to focus on age-related macular degeneration, a topic that we've not touched on at all. So over to you, Doctor, to introduce age-related macular degeneration.
Right. Thanks, Fatima. Thanks for having me back again. So, yes, age-related macular degeneration, as the name itself denotes, it happens with aging. With age, your macula degenerates. Okay. We call it, ARMD in short. So, what's the macula? Macula is probably, now for the listeners, it's all totally new words, except for the age, right? So macula is I would say the most important part of your retina. Retina is the sensory nerve or the sensory input to the eye. That's where all the images have been formed. So the most important part of the retina is actually the macula, where you have your pristine vision. You get the best vision of the macula. So if your macula is not there, you will have some vision, you will see something but not everything, right? So the acute vision is preserved at the macula. So this macula can degenerate with age. Not everybody gets this, only a subset of people will get this. So I think as you recall, previously we were talking about the commonest causes of blindness. One being cataract, two being glaucoma, three in the Sri Lankan context is diabetes, of course. But in the developed world, it's this age-related macular degeneration. So Caucasians or white people, for that matter, will actually get this more commoner than in the Asian population. But it's not uncommon here. So so generally it happens after around the age of 50s, and with age this macula degenerates, so the vision actually deteriorates. So as opposed to other diseases of the eye, as I mentioned before also, most of them are silent killers, glaucoma, diabetes. But here you can call it a silent killer, but this actually you will realize, when your macula kind of gets affected, you will realize that something is going wrong. Your vision is kind of not as what it was, and then of course you'll be presenting to the eye surgeon, and then of course we see and come to a diagnosis. Right. So there are two components of age-related macular degeneration. We call it dry and wet. So the dry disease will always be there. In those who have this, the dry disease will always be there. So your macula actually degenerates with time, and there's little we can do actually, there's little we can do to kind of halt the progression. There are a few things, we'll talk about it in a minute. But it kind of, it's a very slow progressive disease. You will have less vision yearly. If you check your vision in not only the visual acuity, all the other components, there'll be a slight deterioration, but you will not actually realize that something is going wrong. And then comes the wet disease. So all the dry disease people will at some point sometimes will get the wet disease. Now wet disease, if we go to the pathophysiology, there will be new vessels sprouting out into the macula, so there'll be practically bleeding at the macula. So if that happens, your vision drastically goes down. Now, dry is much commoner than wet, of course, but wet is more devastating than dry, right? Because your vision goes off just like that, and if you don't do timely interventions, you will just lose your vision, and once you have lost your vision, there's no turning back. You can't get what you have already lost.
So, Doctor, there's something new to all of us. And you talk about the macula, and you said it's in the retina. Is it possible to tell us, I'm sure listeners would like to know, where exactly is it? The retina is in the eye.
Yeah.
So where is the retina and where is the macula?
Yeah, so retina is the sensory layer of the eye. So it's all over. I mean, if you get a cross section of the eye,
Right.
all the rays kind of gets focused and gets the image on the retina. It's like the film in a camera, right? So this image is being processed in the brain, but all the sensory layer is the retina. So it's all over the eye. I mean, inside the eye, if you get a cross section, it's entirely the whole inside of the eye is covered with the retina.
So that's what is actually, as we know, because thank you for explaining, and so it actually is more or less the whole eye. Is it correct to assume it that way?
Yes, so it's like the film of the camera, it's inside the camera, the film is inside the camera, so likewise,
right.
The retina is inside the eye and is not exposed to the outer world, because if it exposes, the retina will kind of get damaged. So what is being exposed is only what we allow it to be exposed. So that's where the lens and the outer part of the aperture, in the camera, like in the aperture in the camera. So the lens and the iris all modulates the light and gives what is required to the retina, and the image kind of gets formed in the retina. So out of that, the whole retina, the focusing point is where the macula is. So that's why macula gets the most amount of kind of blood supply and all, and it's been nourished very much, because that's where your acute vision, the best vision is. So if you don't have the macula, you will have some peripheral vision, but the acute vision, where you can read the whole board, all the small lines and all, that is modulated by the macula. So that's why this is very important. If the macula gets hit, you will have more trouble living your day-to-day life than being hit elsewhere in the retina.
So every person, once they become 50 and they progress in age, has to expect this type of degeneration in whatever form, maybe mildly or maybe more severe.
Yeah, not necessarily, right? So it doesn't happen to every 50-year-old. So more than 50 is one of the risk factors, right? So if I go into risk factors, yes, age is the most commonest risk factor. That's why they call it age-related macular degeneration. Family history also plays a part. If your family members have this, there's a tendency that you might have it. Then smoking, poor dietary habits, like with the sedentary lifestyle, with high lipid intakes and all, there is a correlation between that and this. And then of course hypertension is thought to be one of the risk factors, and dyslipidemia, that is cholesterol and high lipid levels, are thought to be risk factors. And again, sunlight. So sunlight, especially the UV rays, is thought to be one of the risk factors in disease progression, and of course having this disease. So there's no way we can predict you will have it or not. It just happens, and if it happens, there are ways to kind of halt it, but there's no way of kind of stopping it.
So it can happen.
It can happen to any one of us, yes. And yes, if you have the risk factors.
So once it affects a person's vision, or a person's vision is affected,
yes,
and then obviously the person will seek medical attention.
Yes.
And that is where you will be able to diagnose what exactly it is.
Yes.
So how common is this situation?
As I told you, it's the third commonest cause of blindness worldwide, right? So it's not uncommon, and it's not very common as well. In the Sri Lankan context, it's not that common per se, but probably it's a bit underdiagnosed in Sri Lanka, so that's why it's not coming up on the charts. And of course, diabetes being very prevalent in Sri Lanka and mismanaged a lot. Diabetes actually, overhauls age-related macular degeneration, but age-related macular degeneration is there, in Sri Lanka as well. And of course, the sedentary lifestyle, we are embarking on, also, plays a part in the disease progression.
So what is the solution?
Yes, of course, there's always a solution. So the dry disease, as I told you, dry is the more indolent one, wet is being more sinister. So dry disease, there's no solid way of controlling it. We give lifestyle modification advices like stop smoking, do it for better dietary habits, and if you're hypertensive, of course, control it. You can't control the age, of course. Everybody grows older. So then of course there are with the dietary habits, there are dietary supplements like multivitamins we can prescribe to subdue the progression. It will not stop the disease. It can halt the speed of progression. So it also affects. Studies say only 1 out of 5 people will actually get affected with the vitamins, and also in that 1 out of 5 only there will only be a 20% reduction of the progression speed. So only a minority will get benefit, and only to a very small the numbers are very small. So I mean, there's nothing else we can do. So we can prescribe the multivitamin for 3 months or so, and then see how the progression goes on. And then comes the wet disease. Now, when a patient comes, of course, to the clinic, we have to make a diagnosis first. So we take a frontal photo, and also we do a OCT scan, that is a cross section of the retina, to come to a diagnosis. So these will be done quite regularly in these patients to see the progression. So once the wet disease comes, you will suddenly realize there will be a reduction in vision. So the first symptom you will get is what we call metamorphopsia. That is, straight lines can get a bit wavy, right? So in dry disease, if we find an age-related macular degenerative patient, we actually give Amsler grids. There's a grid called Amsler grid. We can do it. You can do it at home as well. So to monitor yourself, to see whether these straight lines actually go wavy. The first instance it goes wavy, you're supposed to go see your eye surgeon. Why? Because the wet we can actually control. So I normally tell patients, now these are like 2 beasts eating onto your retina, into your macula. One is dry, one is wet. Dry is a very slow eater. We can't control it. It will keep on eating at a very slow pace. You will not even realize it. But once everything is been eaten, of course, it goes away. But the wet is a ferocious eater. It keeps on eating, and once everything is left, once everything is gone, there's nothing to eat, it will just go away. So this we can put a leash on. That's where we get those intravitreal injections. We inject drugs into the eye. So those who are having injections will actually know about this. This is one of the causes we inject the eye for. So with the injection, we try to stop it at that stage. So once you arrive after the disease has progressed to a level that the beast is not there anymore, then we can't actually help you. Even with injections, we can't regain what is being lost. So before losing your sight, we give injections to stabilize it to where as it is. So if you come early, we can inject early and get your vision to, maintain your vision at whatever stage they are. But if you come late, of course, we'll have to work with that stage. So injections can be lifelong. There are patients who just get 3 injections. There are patients who gets, for 10 injections a year for the last 5 years, and 50, 60 injections. You might be injection dependent as well. So you're in for a long haul. Then I always explain patients, it can be 3 or it can be 50. We never know, right? But that's the only option we have. So injections also, there are several classes of injections. We start off with a very basic, and we give an induction phase. We give at least 3 injections and then see how it reacts. That's where all the OCTs, the scans I was talking about, comes into play. We do serial scans to see how the progression is, and if the injections are working, we can actually continue it until it gets fully dry. And then, of course, if it doesn't work, we can switch the class to much more expensive injections. But there are ways to control it. And the important thing is to see your eye surgeon whenever you feel anything. Of course, you see wavy lines and all, and of course adhering to the proper plan, because injections only work for 4 weeks, 4 to 8 weeks in some injections. Beyond that, the strength of the injection is gone. So you can the disease can come back again. And if you just stay home without injections, sometimes when you come back, even if we inject, we will never get what you had before.
Now, can this happen in both eyes?
Yes, it's a bilateral disease. Both eyes age together. Both eyes have the same genetic predisposition, same risk factors. And then, of course, yes, both eyes do get affected. But more or less in common practice, we see one eye being affected much more than the other. And of course, in many cases in in countries like Sri Lanka, we actually, when the patient comes, it's more or less the only eye, because the other eye is all neglected, has got affected, and is already blind. And they come because the only seeing eye, they realize something wrong, and to see that the other eye is almost gone, and we can just save the index eye alone.
So what about creating awareness about this? How does that happen, doctor, in any way? Or would you say that when there is you have eye clinics in all the hospitals,
Yes.
and when they do come for something like maybe with a cataract, will they be advised that any day this can happen as well?
Yes.
And therefore they should watch out.
Good question.
And seek attention fast.
Good question. Awareness is a very it's in the Sri Lankan context, not only with this, not only with age-related macular degeneration, with any eye disease or with any disease for that matter, the awareness is a very key factor, and which is very lacking in the Sri Lankan context. Now, I was talking about diabetes as well. There are lots of diabetics who comes to us with eye diseases at the very late stage. So same goes with ARMD. There are measures being taken now. I told you sunlight is also one of the risk factors. Now all the glasses are UV protected. All the spectacles right now which are being prescribed are actually UV protected glasses. So that is now a common standard in Sri Lanka. And then of course we advise now. We don't. There's no awareness program as such, but if we get a ARMD patient, if by chance we see drusen and other early signs which can help us tell the patient that you are at risk, in these patients we of course advise them to wear sunglasses when going out, and also have your dietary habits more strict in a healthy way. So these advices are being given, but as you said, in a normal routine clinic, there's no such awareness programs which goes on hand in hand. But of course, there are posters and banners being hung around in the clinics to give awareness, just like in glaucoma, diabetes, and also this as well.
At least that something is being done.
Yes.
To make the public aware.
Of course, yes.
When they come to the eye clinic, that while they're waiting to see the doctor, they can see these messages that are put up.
Yes, most of the common eye diseases are being displayed, of course, so ARMD is also one of the commonest.
Just a question, doctor. Time is catching up with us. It's like I would say we think, not you, us the lay people, that wearing dark glasses to cut off the rays, the glare, does help. Now, if a person is wearing glasses at a younger age, then it can be according to the prescription. Otherwise, still to get your eyes tested and get a proper pair of dark glasses, not just anything that you can find available for sale, but get it from a reputed place. And wear, because they feel that helps a lot in protecting your eyes and future issues, eye-related issues. Could you comment on that, please?
Yes, of course. Now, as I mentioned before as well, now 40 is probably a very good cutoff if you have never seen an eye surgeon at all. 40, by the time you're 40, everybody will get what this called the disease of the 40s, presbyopia, where reading can be difficult. So you inevitably will have to wear glasses to read. So just without going, over the counter to buy glasses, of course you can go to an optician and get the glasses done. They will just do, give it, and of course you can just online order some of the glasses as well, because just for reading prescription, it's a universal thing. But it's better to get your eyes checked by an eye surgeon, right? Why? Because of these all, unrelated or silent killers of the eye, right? Glaucoma being one of the main ones. And if you're a diabetic, of course, every year you have to get your eyes checked up. I mentioned this before as well. And of course, if there are features of age-related macular degeneration, we will be telling them. And then, yes, it's always good to get your glasses done by a reputed optician. That's always, in any case, that's a universal, norm. And then, yes, sunglasses. In the Sri Lankan context, where we live closer to the equator, sunglasses is always a good thing to use when going out. So it's not only about the fashion, right? It also helps in some of the eye diseases, age-related macular degeneration being one of the top ones which can get affected. So yes, don't be shy to wear sunglasses. It's always a good thing, especially in our part of the world. So yes, right.
Thank you, Doctor. And so what is your take-home message?
Yeah, so again, regular eye checkups is very good. 40 being a cutoff.
How regular?
Yeah, so 40 is a cutoff, and if of course if it's if you're okay with by 40, we'll be telling you okay, just get the glasses done. After 50, it's better to get your eyes checked maybe every year or maybe every 2 years, right? And of course, if you're a diabetic or if you have any other eye-related other diseases which goes on, you'll have to see your eye surgeon much more earlier. But let's say after 50, every 2 years, whenever you feel that your glasses are not working anymore, of course you'll have to change the prescription. It's better to get the prescription from an eye surgeon rather than just walking in and getting your glasses done by an optician.
Thank you very much, Doctor. And there we end a very interesting discussion on age-related macular degeneration. To you, Dr. Duleepa Baranage, consultant eye surgeon, National Hospital, Kandy, we say thank you so much for being with us on the program.
Thank you very much.
And sharing your expertise on this very important topic. Thank you, Doctor.
Thank you.
Thank you too to Prabhavira Surya for technical assistance. I'm Fatima Razi Kader saying good night. And looking forward to your company next Monday, same time on Views on Health.